I'm honored to have the opportunity to speak in this great meeting. I,
Mics, please.
I think it's okay. I think it's okay. I just have to speak louder, as always. I thank you for the invitation, the GEA Heart Valve Clinic, Dr. Sparias, Dr. Patakos, and I will proceed. I have a case to present, as we were asked, and so it's about a lady, 75-year-old, small, relatively small, who presented with shortness of breath on minimal exertion. She had a severe stenosis of bioprosthetic aortic valve, a trifecta, which was implanted back in 2018. It was a trifecta, 21 millimeter. She had as risk factors hypertension and dyslipidemia. She was on permanent atrial fibrillation, and she had moderate renal failure with an eGFR around 50, without any other specific problems from her lab work. And she was in atrial fibrillation with a QRS duration of 70 milliseconds with no other abnormalities. The coronary angiogram performed back in June 2022. It was a case that was performed in 2022. Showed one vessel coronary artery disease with a mid-LAD 60 to 70% stenosis and focal mid-ostial PDA stenosis, which was not important. It's better? Okay. The ejection fraction was 65%. The LV was not dilated. She had severe bioprosthetic aortic valve stenosis, as mentioned previously, with a Vmax of 4.2 meters per second, a valve area of 0.7, mild AR, and moderate mitral and tricuspid regurgitation, without significant pulmonary hypertension, just mild, and preserved RV function. The Euroscore 1 was more than 20%, but the Euroscore 2 and STS score were not too high, but she was a frail, small lady. So we discussed about her with our cardiac surgeons. We tried to see further with a CT scan what would be better to do. So the CT scan showed that it was a trifecta with an internal diameter of 18 millimeters, rather small coronary sinuses with diameters between 26 and 27. The smallest was the left with a diameter of 26.6. Very, very low coronary ostia, especially the left was at 7.7 millimeters from the annulus, and the right at 11, and very low sinotubular junction as well, and narrow sinotubular junction with a diameter around 22-23. When the virtual valve was positioned in the anatomy, it seemed very difficult to accommodate a 23 millimeter evolute, which would be the first choice to treat with a TAVI. So we went back to the surgeons and we tried to avoid the bitter glass of which was approaching. But they persisted that she was not a good surgical candidate because she was very frail, and that we should perform TAVI. So it was obviously a case of very high risk of coronary obstruction. The axes were mildly, there was some tortuosity, but the diameters were okay and there was not much calcification, so the axis was not the problem. And we went to premeditate with the valve-in-valve application. So the trifecta is 21, is a valve with an internal diameter of 19. It is non-fracturable, although in the literature there are some reports that some attempts of fracture have been made with high-pressure balloons, but it's not the case for the average case. Okay. But we see how an Evolut 23, which would be the valve of choice, should be implanted, having as target 4 millimeters below the annulus of the bioprosthetic valve. And we see what would happen in our case when the leaflets of the external leaflets of the trifecta would be pushed at the side from the new bioprosthetic valve. It was almost certain that the left main at least would be obstructed. and it would not be obstructed just because of ostial obstruction of the coronary, but also because of sinus sequestration in our case, because the STJ and the VTC and the V2-STJ trended to 0. So it would be a case of almost definite obstruction of the left main. So what would be the options that we would have? One is snorkel or chimney stenting. This is a report, a registry of 16 centers, 60 cases among 12,800 TAVI procedures, which means that it is necessary in 0.5% of cases in this registry. They had some failures with deaths during the procedure, but only 3, and this happened only when the obstruction occurred because there was no wire protection. When the chimney was done correctly, there were only 2 cases of stent failure at 6 months because of in-stent restenosis and 1 possible late stent thrombosis at 1 year. So according to this report, chimney or snorkel stenting is an acceptable bailout technique for coronary artery obstruction. The higher event rates are expected when established coronary artery obstruction without wire protection happens. And the short and mid-term results are acceptable. The long-term follow-up, though, is always a question. The other solution for this case would be basilica, which is something that, as far as I know, has not been performed in our country yet, and is a complex procedure that needs about 3, I think, at least skilled interventional cardiologists. There has been reports that describe the technique. Very good imaging is needed from the CT to predict the best angulation for the X-rays, and also a guidance by a very experienced echocardiographer with a transesophageal echo. It should be done under general anesthesia. And what happens in this technique is an Astato 20 wire crosses with instantaneous electrocautery the menacing leaflet towards the LVOT, where it is received by a loop, a snare, externalized. A flying V is formed by the operator, and then it goes back in the leaflet in order to do a new electrocautery to create an incision this way and a splitting of the leaflet, thus avoiding the obstruction of the coronary when the bioprosthetic valve is implanted with the TAVI procedure.
Costa,
yes.
Just interruption. What are the hemodynamic echo sequences of basilica or other leaflet splitting techniques until the implantation of this?
There is a very delicate moment when the splitting happens. There is acute AR, not always hemodynamically significant. There is no hemodynamic impact always, but it should be expected. And the valve must be prepared to be implanted very quickly in order to correct the situation. That's the problem with this technique. One must be very fast from the leaflet splitting until the valve implantation. Okay. If the AR is hemodynamically significant, one trick that one can use for several minutes is to pace a little bit higher at 120 BPM in order to minimize the impact of the acute regurgitation, as far as I know.
And another question, what happens if coronary intervention is indicated after chimney stenting?
This is a problem. One should be, not many reports have been made. There has been one published by Dr. Taleb, I think, that it is described for a chimney with, I think, not a self-expanding valve with a tall frame, but with a balloon expandable valve. It has been done, intercoronary intervention, through the stent that is as a snorkel outside. And to do that, you must be cautious not to cross crisscross the struts of the chimney stent. You must create a loop, be in the stent, and then in order to do the intervention, you can try to put an extension guide catheter in the stent. It can cause hemodynamic compromise because the extension catheter can block the supply. So you have to be fast.
Okay.
So it's something that is difficult, but not always feasible. It has been described. I think it's not always feasible.
Okay, we can continue.
So for this case, our planning was to do general anesthesia in order to have a patient that will not move because we had a complex technique. Our main access would be the right femoral artery with echo-guided puncture, pre-closure with two per-close. A secondary access would be the left femoral artery for the guiding catheter for the left main, which would be an XB3. The right radial artery for a JR test for the right coronary artery. We should start with a fast PCI of the middle AD lesion, and then position wires and drug-eluting stents standby in the coronary arteries, left and right, in order to use them in case we will need it during the TAVI. We would cross the valve conventionally with an AL1 and a straight tip guide wire. We should use a Safari extra small. We would pace over the wire during Evolut 23 deployment. We would assess before final release of the valve the coronary perfusion to decide if snorkel stenting is needed. We should have IVUS available, and we should close at the end and assess finally what happened. So that's how it went, a fast stenting in the LAD. Then guiding catheter and a stent in the LAD through a wire, a guiding catheter and a stent in the right coronary artery through the other wire. The first step of the implantation of the valve at the depth that we intended went well, but before final release, we assessed what happens at the right coronary artery and at the left main. At the right coronary artery, there seems to be some distance from the frame of the valve to the ostium. On the left, the aspect is ominous, and it's from the image that we had, it would be certain. It seemed certain that the left main would be blocked in case we released the valve without protection. So we decided before the final release of the valve to implant a stent. The stent that we had selected, by the way, was a high radial force stent. The diameter was 5 by 35. It was 5 diameter and 32 the length. We tried to target the distal left main and to be above the senotubular junction at the proximal part of the stent. We implanted it as we saw here. And then on the left, you see the final release of the valve. And on the right, the final result with injection from the guiding catheter for the left main, which was retracted a little bit higher. So we had an hemodynamic measurement here. You see the pigtail in the left ventricle. We had a good hemodynamic result without a gradient more than 10 millimeters of mercury. We thought about post-dilating, but it was a trifecta, and we had a stent that we had a good result, so we decided not to do anything more. We wanted to verify that the right coronary artery would not be blocked after the release, after withdrawing the wire, so we did a final check with IVUS, and with IVUS, we saw that the ostium of the right coronary artery was clear. There was no leaflets prolapsing or menacing the ostium, so we didn't do anything for the right coronary. And this was the final angiographic result with the pigtail, and the final angiographic result at the axis. So the patient
Another
went well.
important question is if there is an increased risk of stroke with this kind of techniques for these patients.
I think that with any technique that increases the number of manipulations in the ascending aorta, it is logical that the stroke risk increases. But I think that with leaflet splitting techniques, it is logical that it is somehow more than with compared to snorkel technique. So I will comment it later as well. I will do some comments later as we advance. Here we see that the alternative that we had is Basilica, but with Basilica, it is not certain that there will not be coronary obstruction. There is a 7% chance that you can have coronary obstruction even with Basilica, and then you must do either snorkel or try to implant orthotopically a stent by crossing in the coronaries through the gap that the Basilica has offered. So the Basilica is not a panacea in case of coronary, when you want to protect the coronaries. This is a more elegant technique that is evolving. This is a dedicated splitting device, which is called Shortcut. It is a device that needs 16 French axes in order to do what is necessary. Here it is an example with a previous TAVI valve that failed. There is a stabilization arm and a splitting element, and it can create elegantly the splitting that was initially the way that for which the initial way was the Basilica. But it needs also very good imaging and very, very skillful operators. In the PCR that follows, there is a promise that they will show good results regarding this device. And there is a more brutal way to get rid of a menacing leaflet, which is called Unicorn, which is like a balloon-assisted Basilica, and you cross the menacing leaflet, you pre-dilate it with a coronary balloon, then with a peripheral balloon, and then you implant a valve inside, totally destroying it. So there's no problem. I think that this technique creates a great risk for a stroke, but it is described in the literature with good results for a few patients. And the more awe-provoking technique is the cathedral, where it is on top of Basilica. There is another lasso which is advanced over through a 20 French sheath, which is just over the annulus, and with the lasso you cause electrocautery, and you withdraw everything and the leaflet comes out. This is a technique that has been described in the 2022. I don't know if there is a large series of cases with this technique, but it is something that can be done, that has been done. So we have, in order to protect the coronaries in such cases, either leaflet splitting or snorkel stenting. The advantages of leaflet splitting techniques is that the coronaries are reaccessible and there is no risk of stent failure. The disadvantages are that if the valve has been a TAVI valve which was not commissurally aligned, there is no sense. And it is technically more challenging with 3 or 4 operators needed and much fluoroscopy procedure time and cost. On the other side, the snorkel stent is more friendly for standard skills, and it's a good bailout high-risk strategy. The disadvantages are the coronary access that we have mentioned and the possibility of late stent failure. In our case, we did a CT scan for follow-up at 18 months, which showed that the result at 18 months remains acceptable. The stent seems well opened without distortion. The patient goes well. There are no symptoms. The valve is above the level of the left main, as it is shown on the right. And anyway, we are satisfied with the result so far. It is a 75-year-old lady. The expected lifetime for this kind of patient, for a woman of her age in our country, should be around 83, 84. We should continue to follow her up closely. So to conclude, this is the last slide. One should know in his institution what is the skill set, the toolbox, and the strategy. And one should be bold, but with intelligence. And there are cases that cannot be done with TAVI, as in this example, where the risk, the surgical risk is high, but the anatomy is impossible, because it is like the previous one, but there are no coronary sinuses. If you see the diameters, the coronary sinus diameter is around 21. There is not possible good result with TAVI for this case. So despite the high surgical risk, we did not attempt TAVI for this case. The patient was operated and she went well, despite the high surgical risk. So to conclude, the risk of coronary obstruction at TAVI can be predicted. Standardized criteria based on CD imaging exist and are well known. Preventing strategies include snorkel stenting and leaflet splitting techniques. Basilica is well standardized but complex and requires specific training. Other leaflet splitting techniques and dedicated leaflet splitting devices are proposed and promised and hold promise. All techniques are promising but have strong and weak points. They all require further evaluation. And we should not forget that if the anatomy is impossible, surgery might be reconsidered. I thank you.
Hey, great. It was a great overview of all these complex techniques. And anyone who has a question, go to the microphone. Anyone in the chat, please send us a question. I can read them here, and we can address those. One thing, there's one more technique. It is the snorkel after recrossing. Because if you saw in your CAT scan, you had the stent, the coronary stent, was released, and then you place a valve. So you crush that stent, or whatever, the entry to the stent is crushed beyond the valve. So if you want to complicate things a bit further, you can have the system there, exactly how it is. And then you release the valve, and you have the coronary guide exactly where you have it. And then you take a second guide and cross back inside from the inside of the valve. And if it works, your snorkel comes now into the main lumen of the valve. And if it doesn't work, you just deploy this one. So if you can make it happen, so that answers the question of Dr. Trikas, what about the reaccess? Because if you crush the stent on this behind the valve, I think reaccess will be nearly impossible. You have to go through the strut of the stent and destroy it and all that. But if you get lucky, and in the other one, you can, because the catheter, the stent comes into the main lumen of the aorta, you can find it a little bit and try with a guideliner to access. I mean, nobody really plans to do those things, and it's actually highly unlikely, in my view, to require them. Because as you saw, these coronaries, they don't really have disease. So, and we're really talking about a very big vessel, the left main and the access towards the aorta. So it's highly unlikely, unless somehow it ends up in the circumflex or the LAD and it's oversized and you end up with a dissection acutely. Yeah, that could be a problem. But if it doesn't, unlikely that this person is going to have a left main restenosis, let's say, or something like that, because they really don't have atherosclerosis of that degree.
I think for this case, since the valve was above the level of the left main, it would not be possible to have an orthotopic stent through the struts of the valve. So that was the only solution. I agree that
talking in general. I'm just talking in general. In the in the overview slide, there is the addition snorkel plus.
Can I ask something?
Yeah, go ahead.
Yeah. Congratulations, very good.
Dr. Dardas, yes, very well.
Yeah. Very good and elegant case. I want to ask you, did you deploy the stent before deploying the valve? I didn't get it right.
Yes, I showed it. Yes.
So you first deployed the stent and then you deployed the valve?
Yes, because we would not have to face the situation where the patient would be hemodynamically unstable, because it was certain that the left main would be obstructed. So if we implanted the valve and then consider if we implant the stent, then we would have a patient hemodynamically unstable.
Okay, I agree with that, but there is always an issue of compressing the stent when you deploy the valve. So in these cases, I mean, what is our usual practice? Because I saw your guide catheter was quite high. So if you wanted to go down again, you may, you possibly wouldn't be able to go down and post-dilate the stent. So in these cases, what we do, we leave an extension catheter just near the ostium of the left main. And the extension catheter is more easily maneuverable. So we post-dilate the stent after deploying the valve, so we make sure that the stent is properly deployed.
So congratulations for this case, nicely performed and presented. So I think all looked unfavorable to begin with. Valve-in-valve procedure, valve with external mounted cusps, narrow sinus of Valsalva, short distance between the annulus and the orifice of the coronary arteries. So I think in this case, considering that the internal diameter of your first valve was only 19, the choice of putting a valve with a supra-annular opening was quite reasonable to decrease the possibility of residual gradient. However, what I would like to ask, do you think that, did you consider putting a balloon expandable valve? Of course, this would perhaps leave you with higher residual gradient, but do you think that a balloon expandable valve would kind of decrease your risk of coronary occlusion? And a second short comment, as Dr. Trika said, these procedures are related to a higher risk of stroke, so using cerebral protection like the Sentinel would be a reasonable option. However, I realize that you run out of arterial accesses. You put one access for the TAVI procedure, pigtail, 2 guide catheters, so perhaps it was not reasonable to do that.
It could be done if we, I mean, for the cerebral protection, I start from the second question. If we opted to use the secondary access, the secondary femoral access, with a larger sheath, so we could have 2 guiding catheters through a 12 French sheath, for example, and close with 2 proglides, because we knew that we had relatively good puncture points, and we had no difficulty puncturing echo-guided. So if we wanted to do this, yes, but it would add to the complexity of the procedure. In this way, the procedure was smooth. And the first question was if we would select the balloon expandable valve. It was, the internal diameter was 18, not 19, from the CT. So we thought that it would be not a good option, and since the leaflets of the bioprosthetic valve would anyway go up and close the coronary, even in this, with this choice, we did not do that. We opted for this solution and hope for better hemodynamics for a small annulus. She goes well. At 18 months, she's well.
Okay. I will have to stop here. Thank you very much, Dr. Triantafylou, for excellent presentation.